Lovely. So welcome, everybody. Thank you very much for coming. I'm sure there'll be a few more people joining as we go through. What we wanted to focus on in this session, and we're really fortunate to have 4 of our new regional conflict champions with us. We wanted to introduce you to the new NHS MMF e-learning course, foundation course in managing conflict, and also to introduce you to 4 of our champions talking about their role. It's a really exciting project which we hope is going to continue and roll out. Just to start with introductions, for those of you who haven't been to one of our conflict cafes before, I'm Sarah Barclay. I'm the founder and one of the directors of the Medical Mediation Foundation. It was set up in 2010 to offer really a space where we could support families and professionals where conflict arose and try and think in a sort of structured way about how we could sort of support the identification and the sort of collaborative, compassionate management of conflict, and also offer mediation where there were disagreements about communication or treatment between healthcare providers and families. And before I go on to talk a bit about the course, I'd just like to introduce my sort of co-conspirator, if you like, Essie Menson.
Thank you, Sarah. Yes, I'll give a little bit of background about myself as to how I became Sarah's co-conspirator and how she really helped me think about the whole area of conflict differently. So as a clinician who worked in an area where I was used to talking to families about difficult diagnoses and discussing things that they might find really difficult to hear, I thought I was a pretty good communicator. Most interactions went well, despite the difficult circumstances, but on occasion they didn't. And though they were rare, those cases, it really affected me and they really threw me. Why was the best I had to offer? Careful explanations, maybe summaries of the best, latest evidence. Why was that not making a difference? Why was it not preventing conflict? When I partnered with MMF, who were already studying this area very intensively, we undertook further research into conflict in the children's healthcare setting and realized that conflict was happening at different levels all around us. The initial survey of staff at the Evelina, asking them how often they encountered conflict, was really illuminating. And all the research that we've undertaken has underpinned the research, the training that we've developed ever since. What I learned was that there were skills and strategies that I really wasn't aware of, that my focus on explaining better, giving better evidence was not really the right focus. And I was missing a whole lot of understanding about conflict and the impact, not just on myself, but on the families and of course on the child. And that's underpinned what we've since developed. And as Sarah will talk about, is the basis of the foundation course that we've developed with NHS England. It's a pleasure to be here with you.
Thanks, Essie. We thought that we'd start just with a reminder, and I think some of our champions are going to talk about this well, of just why this matters so much. And it's because of the impact that conflict can have. We introduced the e-learning course at the Royal College of Paediatrics annual conference in May, and in a workshop, and we asked people to enter words into a word cloud, which really described the impact of conflict on them, and just a huge variety of really strong, mostly negative emotions, which really across a spectrum of emotional impacts, physical impacts as well. And it always strikes us every time we do this that there is a sort of a core group of very, very similar words there. And of course, when we say who else might be feeling similar things, it is the family, the families, the patients, the parents, the caregivers as well. So it's a reminder to all of us of, I suppose, where conflict can come from and the fact that everybody may be feeling quite similar emotions. We wanted to play you a short selection of clips which appear in the e-learning course, 2 parents, 3 professionals, I think, talking about the impact of conflict on them, just to give you a flavour.
it's the morale on the ward. You can sense the. I mean, it's really a palpable, horrible situation, and it's not only on the ward. Because many of our patients, they're very long-term patients. It happens in clinics. Our administrators fear the phone call, and it's a really difficult for everyone. And it's not only at work, but a lot of my colleagues take this issue home with them, and it affects their everyday life. People lose sleep. People call in sick.
It's a battleground for everybody. It's a drain on everybody's energy. It's not a nice place to be for everybody. And I think it's not just like sort of parents with complex children. It's not just a one-off. It's because, like sort of parents like me, you get labelled. And then it's just one admission after another, after another, after another. And it's just a cycle. It makes me scared, and it makes me lose my my reasoning. I feel that I think in a different way because I'm worried and I'm scared, and I feel that I don't like that sensation of anger. It gives me a kind of, as much as being psychologically, it affects me in a sense that I get upset by it, but also viscerally, I can feel it within myself. So I get quite sweaty, I get quite shaky, and therefore I think that it takes away then my scientific reasoning and my ability to be able to provide good care.
Well, it can feel very personal. I think in some ways with medicine, there's the knowledge and the decision making and the application of medical knowledge to a clinical problem, which most doctors are kind of trained in and can do well. But the thing that makes you unique as a doctor is how you interact with your patients to get the care delivered. And as a result, the relationships that you form are hugely important, and they're really powerful, and they form such an important part of the care that a child receives. So if that's going wrong, it starts to make you feel that you can't deliver the care that you want to deliver. And it makes you question why it's going wrong, and is it your fault, and are you somehow not doing a good enough job?
It makes you feel dread. I would say if you're in that kind of situation where it's broken down, you dread. If from a healthcare perspective, you dread coming to work, and you dread potentially going to where that patient is, or if you're in charge of the unit, or if you're looking after that patient, you dread it if you've got to spend 12 hours with them.
Conflict's a key word. For me, conflict means you've already lost the battle. The conflict has happened. You're in a disagreement situation. That's nearly impossible to come back from, in my view. It takes a long time, as I mentioned, to build the trust, build that up. But conflict can kill it in a second.
Really powerful. That last one was a parent, was a father. So to give you an idea of where we've got to in this journey, and really trying to spread some of the resources right across children's medicine in the NHS. NHSE came to us last summer and wanted to develop an online e-learning course that would be freely available to staff working across children's healthcare in the NHS, which would give them a foundation in recognising and managing conflict. And it's part of a conflict management resources hub that's set up on the NHSE website, and which is accessible to anybody with an NHS email address. And it has a combination of resources on there. We have the training program that I'll just introduce in a moment. We also have some resources for families, and that will increase. I think it's probably the least well-resourced at the moment. There are a range of professional and wellbeing resources, and there's a structure to work through when conflict arises, and that's supplemented by a framework for managing conflict that we also do teach in our sort of higher levels of training, really all aimed at supporting health professionals and families to recognise and manage those really challenging, impactful situations. So just to give you a brief description of what's in the course, it's very interactive, and what we've tried to do is to have a combination of sorts of videos and first-hand testimonies that you just have seen there, some vignettes with actors role-playing different scenarios. We have a lot of discussion with the facilitators of the course. There are quizzes that people can do to check their learning as they go through. And it's recently been endorsed by the Paediatric Critical Care Society and accredited by the RCN, and we're just waiting and hoping that we'll also get endorsement by the Royal College of Paediatrics. We'll show you the QR code again at the end for how you can access it, or come back to us and we can give that to you. So it's 3 modules, and the course is very self-paced. Each module takes about an hour to complete. And as long as the tech is working properly, you can save it as you go along. There are a few glitches still to be ironed out, but I think we're getting there. So in the first module, we're looking at the introduction to the causes and impact of conflict between families, patients, and professionals. Then we look at how to identify the triggers and the warning signs. And in the third module, really focus on some of the skills and strategies, which we hope will be helpful in managing and de-escalating potentially difficult conversations.
It's on video and I don't want them to see me put the light out.
Thanks, Essie. Just to give you a flavour, we look at the causes of conflict, and based on the research we did initially at the Evelina, when we were tracking conflict cases over the same 3-month period, over 2 years, and these were the top 4 causes that were cited by health professionals. Important, I think, just to mention that those last 2 would not be causes that would be cited by families, but what we were trying to do was to get a sense of what were the key triggers, what were the key causes of some of the conflicts that we were seeing. And we look at the conflict pathway, and what we've tried to do with the conflict pathway, which was based on a lot of in-depth interviews with families and professionals who'd had direct experience of conflict, was to turn it into give it a shape and a vocabulary which would really support the early recognition of conflict and sort of an understanding of what some of those key triggers were. So we work through with examples and little vignettes and active vignettes at each stage, so we can give examples of all the different factors in each of those phases, in the green, the amber, and the red. And of course, what we're aiming to do with all of this is to either support people to stay in that green zone or to come back to the green zone if conflict has escalated. And this is an example of one of the trigger scenarios that we look at. And it's in a way, a very common scenario that we might see in an intensive care unit. But what we try to help people to do when they do the course is to really unpick the triggers. What might they be from the perspective of the families on the one hand and the professionals on the other, so that we're drilling down into those communication issues where sometimes the wrong word, the wrong place, the wrong time, you can see conflict beginning to escalate, and awareness of what those triggers might be, we've found can be very helpful in just helping people avoiding going there in the first place. So in the course, we'll be asking people, when they've looked at those scenarios, to just think for themselves about what are the possible triggers from the parent's perspective, what are the possible triggers for conflict from the professional's perspective. And then we look at what we've called the toolkit for de-escalating conflict, but some of those essential verbal skills that are very transferable, and all health professionals will have come across all of them in their training, but perhaps not in the context of managing conflict. And they're exactly the same skills that when we train professionals to be mediators are the skills which can really help families to feel heard and to feel acknowledged in what they're saying, even if the professionals aren't agreeing with it. So we drill down in and give examples of each of those in the hope that they will really add to that toolkit in those moments when perhaps a conflict comes across you when you're not expecting it and you're on the receiving end of an angry or an upset parent. And we hope that those skills will be useful in just helping you to take a step back and really explore what it is that's going on for that family. This is just a flavour of some of the things that people have entered into the course. We look at in the third module, we really try and drill down into the importance of listening and conversely, what it might mean like not to feel listened to, or what you're seeing if people are not listening. So some really powerful examples, which really you're trying to get people to think, okay, so actually, why does this matter? Why is listening so important? What are we seeing? What's the impact of that if we don't feel listened to? And then finally, we have a demonstration to bring all of those skills together using actors, a demonstration of a really angry conversation where there's no engagement, there's no acknowledgement, and then the converse. What might it look like to do things differently? And what would the impact of that be? So the focus of much of the foundation course is on those skills, on language, on recognizing the triggers and the warning signs, and really putting a vocabulary around conflict, just as we might put a vocabulary around the recognizing of clinical symptoms. So the hub, if you want to just take get the QR code now, please do, but we'll also share the slides so that anybody with an NHS email can log in and get those. Anyone who doesn't have an NHS email, please get in touch with us and we can help you to access the course in other ways. The other really key pillar of the work has been the creation of the Conflict Management Champions. And before I hand over to them, just to say that this is an initial pilot funded by NHS England. There is a conflict champion in each of the NHSE regions, working one day, some days, 2 days a month, with the option for more hours, and supported by training from us. And we do have some key performance indicators. The idea behind all of this is that we try and embed the e-learning course in as many of the children's hospitals across the NHS as possible, so that it becomes more sustainable and the training becomes, certainly in some places, very much business as usual, so that there is that development of the shared language right from throughout the organisation in recognising and managing conflict. So we have 7 and we have 4 of them here today, and I'm going to stop sharing the screen now so that we can introduce you to them. And I think we're going to start with Renee McCulloch from Great Ormond Street.
Hi, thanks, Sarah. Hi, everybody. It's great to be here with you today, and I think this is a first for me, and I'm really interested in what happens in a conflict cafe. So I'm Renee. I am a consultant in paediatric palliative medicine, and I've worked in the field for about 25 years now. And what I have noticed over the last 5 years is how prevalent conflict has become in our day-to-day practice, and how the world of paediatrics has changed incredibly, really, over my kind of tenure. I don't feel too old, but I am in my early 50s. And, you know, over my tenure as a medic, you know, there are some really kind of challenging issues that are arising for us all. And, you know, feeling very strongly actually about how we need to speak to this. We need to, as people are saying, lean in and really start to support our our families, but also our colleagues in what this looks like for us now going forward. And I know Sarah has touched on this in her talk, but just really observing that mismatch of expectation that is happening between what can be done for a child medically and the global perspective that comes with that now, the searching that happens and the challenge that comes with trying to manage conversations and second opinions and third opinions and social media input and all kinds of rationalizing of potential treatment options that we see happening. And then not only that, but just the complexity of differences in beliefs and cultural differences as well that we see, and values in terms of, for me particularly, observing really difficult decisions in end of life care, very much seeing that coming to the forefront now of how we approach what we have to deal with really on a day-to-day basis. So these communication issues and these issues that we see, for a long time I've always felt that communication needs to be learnt. It's not instinctive. We need to have the skills. We need to have common language to know where we're at with each other, so we can align and understand what that experience is like for not only us as professionals working in the sector, but also for families. So we start to have much clearer kind of skill set that's defined. So I was just I was involved in the development of parts of the platform. I was involved in the little house structure that you could see there from some of our experiences at Great Ormond Street, working alongside some really challenging cases, which I'm sure you'll all be aware of from the press. So really this is about how we activate ourselves and how we step into this field. And I'm delighted to be conflict management champion for London, and if any of you are in and around the London region, do get in touch with me and we can talk about how we progress things. But that's me. I'm stuck to some time frames there.
Thank you very much, Renee. Now I'm not sure that Sam is with us yet. We're hoping that Sam Potter is going to be able to come, but Rachel, if it's okay, we come to you next.
Yeah, that's fine. I'm slightly distracted by Erica's dog, which looks absolutely beautiful. Thanks for bringing your dog, Erica. That's always a wellness intervention. So I'm Rachel and I'm the Midlands champion, and I also work as an advanced practitioner across Birmingham Children's Hospital and their critical care transport team. And I've done that for over 20 years now. And I guess outside of the clinical work, I've been quite interested in facilitating communication courses and thinking about research into how we best sort of look after staff and coming at it from that angle, because the more we can look after staff, there's so much evidence now they can do a better job. And thinking about, anyone that works in the NHS at the moment will not be immune to the amount of vacancies and how it's changed recently. I think I looked at the latest figures online, and there's over 100,000 vacancies, and 60,000 of those between medics and nurses. So, it's all very well recruiting more staff in, but we need to plug the holes in the bucket and actually retain staff. And I think this is one of the key areas where we can do some work to support staff. And looking at the Nuffield report, there's a really nice infographics on there, and it talks about if you've been involved in a disagreement, that 49% of our staff actually felt unsafe in that disagreement. And that's really powerful feelings. 45% felt they'd been criticised on social media, and then 66% of those felt they'd actually experienced moral distress around disagreements with families. And we can link, there's a big link between feeling moral distress and compassion fatigue and our ability to be compassionate when we're feeling that. And I know Gillian Colville did a really nice study a couple of years ago now, and one of the big sort of factors into moral distress was the fourth one that was cited by staff was around how when quality of care goes down because of disagreements and communication difficulties with families. So we're really feeling that. And then I guess what we're seeing then, you see sickness from staff increases, and that's increasing year on year in the NHS, or you have staff that have got absenteeism. They are presenting to work, but they're not really fully in that work. Then we know that also increases errors. The staff are much more likely to make a mistake at the bed space when there's high tension and disagreement with families. And I think for me, we will never get to zero. I don't find the term zero tolerance that helpful, because we will never get to zero in conflict. That's just not human nature. But I guess what is in our gift is that we can absolutely equip staff to feel skilled, to feel like they've got the knowledge and the conflict and the confidence to take on these sort of conversations and feel okay in them. And we can build systems around it that support staff to do that. And I think in terms of, I also think of workload, because one of the things I often get asked when we're talking about comms in my local areas, you know, oh, it all takes too much time and it's this and that. But actually, there's quite a lot of evidence that when you can use these skills, and actually you have more efficient conversations, and you probably spend a lot less time in those conversations. And I know, I'm sure all of you have been involved in conflict conversations and just how much time they can take up, several days and hours. So in terms of our workload, we can use these skills and free some of that time up. And I think that's all I'd got to sort of say, really, but just highlighting how much the impact is on staff, really.
Lovely. Thanks so much, Rachel. And Sam, you've arrived at the perfect moment. So Sam Potter, who is another one of the regional champions. Sam, are you happy to go ahead?
Yeah, that's fine. Thanks, Sarah. So yeah, hi, my name's Sam. I'm a peds intensivist in Southampton, and took on this role. I was really excited to see that this role was created because, as I'm sure has already been said, and many people here on the call will appreciate that, you know, conflict just has such a huge impact on all of those involved. And I think one thing where I think this new platform can be really particularly important is how it can minimise the impact that conflict has on families. I think not only is it the family that is directly involved in the conflict, who will of course be experiencing, you know, so many negative emotions around the fear of having such a, what will usually be a very sick child with very challenging decisions that are being made, which is often where conflict arises from. But that feeling that they're having to be by their child's bedside, that their concerns over trust, and that they're really having to micromanage what's going on with their child in order to feel that their child's going to be safe. Having that stress in addition to dealing with the worry of your child must be awful, and we can't really fully appreciate that. And obviously that behaviour comes across as difficult to those who are looking after that child, but actually they're really important emotions and feelings that we all need to acknowledge as part of how we hopefully deal with conflict. And the platform really shows us and helps us to understand that and really understand the family's perspective. We also know that families who experience conflict are more likely to experience worse health outcomes because of that breakdown in relationship with the team, and how that will start to directly impact the care of their child, which is the most distressing impact I think that conflict can have. And so by using this platform and the training that it offers, we can really equip our staff to just be more confident at recognizing those early warning signs particularly, and starting to intervene and being confident to just recognize it and actually acknowledge those feelings and that potential for conflict, and start really working on that, and hopefully preventing it from escalating. I think the other worry is that it's not just the child and that family who are directly involved in the conflict, it's the impact that it has on all of those around that child as well, in that unit, that ward, wherever it is. But those other families will be witnessing those interactions and will be hearing, you know, that family discussing those feelings and the negative impact it's having on them. And that in turn is going to have a knock-on effect for how those families perceive the care that their child is receiving and the relationships that they have with the healthcare professionals and looking after their child. And that in turn can lead to even more difficult relationships and and not only them having more a difficult kind of time with their child's care, but also the healthcare provider struggling even more to provide care. So I think it's the impact that conflict has on families is so profound that anything we can do in our power to minimize that, I think, is just so vital. And not only will the training support staff to feel more confident in that, but there's also a huge host of resources that we'll be able to signpost families to for support, etc. So I think it can only be a really positive thing, and particularly with how it could minimize the impact on families, and most importantly the child, because that's what we're here for. Thank you.
Lovely, thanks so much, Sam. And finally, Steve Playful. Steve.
Thanks, Sarah. So like a couple of the other champions you've heard from, I work in paediatric critical care, and obviously we see a fairly wide range of all types and levels of conflict in critical care environments. My personal experience has been more involved in the supernovas of conflict, which are the high level headline grabbing cases that Renee's mentioned during her presentation, and the ones where we end up in court, usually seeking a judgment to discontinue life supporting therapy. And a particular aspect of this conflict management program is the prospect that we might be able to reduce those cases. And as I think I'll just demonstrate to you, even if we were able to avoid one of those cases, it would have an absolutely massive impact on a whole range of people. Inevitably, those cases end up being associated with very prolonged admissions to paediatric intensive care units, and they are enormously destructive and very expensive in a whole variety of metrics. You've heard Rachel talk about the moral distress that staff experience, and we've done some work in this area, and that's particularly relevant to the nursing staff who look after these patients in critical care. Very often these patients aren't particularly clinically complex, so very often more junior members of nursing staff are assigned to care for those patients. And we've, along with other investigators, have shown that there is more of an impact on the junior nurses, with negative impacts on their mood, feelings of sadness, helplessness and frustration, and has been associated with staff moving on to different posts often. If you think about the financial costs associated with these admissions, it's kind of mind-boggling. So in Manchester alone, over the last 10 or so years, we've been involved in 6 cases where we've had to go to court. And for those 6 children, if you look at the bed occupancy, those cases have been involved with one bed being occupied for 9 years, if you add them all together. And the cost of a PICU bed per day is currently quoted at around £2,500. So just in terms of resourcing a bed space, that's a total of £7.9 million. If you add in the legal fees associated with those, it brings the total for those 6 children up to around £9 million. And if you look at resource consumption, given that our median length of stay in PICU is 3.5 days, that means that for those 6 children's bed occupancy, we could have looked after an average of 938 other patients. And of course, we also see problems for the families themselves. I'm sure all of you have seen families being disrupted, parents losing jobs, impact on other siblings, which often goes undocumented, and various other costs for the family as well in terms of transport and living arrangements. So the one aspect of the training which really excited me was the prospect of maybe reducing the impact of these high level conflict cases that we see. Thank you.
Lovely. Thanks so much, Steve. I'm going to stop recording.